Hello and welcome to Sureena Speaks. And a couple weeks ago I put up a post across Facebook and Twitter asking you guys what specific areas and topics you want me to go over. And I was not expecting the response that I got. So thank you for all of those of you who did get in touch. And in this video I've tried to condense all of that information that you've asked for. Some particular areas I will signpost you onto really great websites where they have a lot of information on there. But let's start off with key parameters. Now, key parameters, it's one of those things where you'll need to know off the top of your head, yes for the exam, but yes for real life too. So if we start off with something like blood pressure, now you might be a pharmacy that does blood pressure testing on walk-in patients, for example. I know that's not something that all pharmacies do provide, but a lot of them do. And so when a patient is asking you what their readings mean, it's really important that you're able to give them that information correctly. So in general and in a nutshell, if a person's blood pressure is between 120 to 80, that is the goal, that is the dream, as it were. That's what we're aiming for. However, you do get two types. You have ambulatory, I don't know how you say it, let's just go with that, ambulatory blood pressure, and you have home blood pressure. Now, ambulatory blood pressure, if it's equal to 140/90 or above that, that's when we would start putting the patient on a hypertensive medication. If it's home blood pressure and it's 135/85, equal to or over than 135/85, that's when we would want to put them on hypertensive medication. Why is there a difference? Well, because in general, when you're in a clinical setting and a person's having their blood pressure taken, they're naturally more anxious than when they're in their own home. So that's why that reading is it takes that into consideration, and that's why that one is slightly higher than the home blood pressure. But in general, 140/90, okay, hypertensive medication. 120/80, hey, we're doing well. Now let's go on to cholesterol. So cholesterol levels, really easy to learn, really easy to remember, because you just need to remember it as 5, 4, 3, 2, 1 and 1.7, but we'll get onto that. So 5, 4, 3, 2, 1, what do I mean? Well, for a healthy adult, we want their cholesterol level to be less than or equal to 5 millimoles per litre. For someone who's at high risk, that would be 4, less than or equal to 4 millimoles per litre. In terms of their LDL level, so LDL, low density lipoproteins, the bad cholesterol, that would be less than or equal to 3 millimoles per litre. And for someone who's at high risk, less than or equal to 2 millimoles per litre. And HDL, a high density lipoproteins, the good cholesterol, we want that to be over 1 millimoles per litre. And what's that 1.7? That 1.7 refers to the triglycerides. So a healthy patient, ideally, we want them to aim to have less than or equal to 1.7 millimoles per litre of triglycerides. So now let's go on to BMI. And again, BMI figures, they're something that you'll have to remember for the exam because they could ask something on it and they'll just want you to remember it off the top of your head. So I suggest writing it down on a poster, sticking it on your wardrobe, on your bathroom door, wherever you're going to see it every single day before the exam. That's going to be the best way to learn it. So let's start off with underweight. So if a person has a BMI value of 18.5 or less, they're classified as underweight. Above 18.5 to 24.9, they are healthy. That's classified as healthy. That's the goal. That's the aim. Between 25 to 29.9, that is classified as overweight. Between 30 to 34.9, that's obesity 1. 35 to 39.9 is obesity 2. And above 40 is obesity 3. So actually the values from overweight to obesity, it goes up in 5, so 25, 30, 35, 40. So actually the values aren't too hard to remember. But yes, definitely remember these before the exam and for when you're practicing as well as a pharmacist, you'll need to know it then too. Now let's go on to emergency hormonal contraceptives, EHC. Now, new guidelines were posted, and from what I can see, there doesn't really seem to be much difference. But to go through it, the most effective EHC available is the copper IUD. What is a copper IUD? Well, it's this small plastic flexible device, kind of like a T-shape, and it's inserted into a woman's uterus and essentially acts as a barrier. So it prevents the sperm and egg meeting, therefore preventing fertilization. The next effective would be ulipristal acetate, as the brand name Ella1, and after that it would be levonorgestrel, as the brand Levanel. Now, if a woman is taking an enzyme-inducing drug, for example rifampicin, then copper IUD is what they would need to go for. But let's be realistic for a moment. As we know, there is a set time frame by which EHC will be effective. And by the time a woman gets a doctor's appointment, has the intrauterine device inserted, they may end up missing that window. So actually, another alternative, if the copper IUD seems a bit impractical to that person's lifestyle, maybe they're very busy and they won't be able to get a doctor's appointment in time, etc., then an alternative that can be given is levonorgestrel, but at double the dose, so 3 milligrams would be given instead. I will include a link in the description box with all the latest EHC guidelines, so do have a skim over that. But from what I can see, that's really what the key updates are. So copper IUD, ulipristal acetate, levonorgestrel. So I got asked about safeguarding procedures and what a person should do if they come across a situation in which they need to follow safeguarding procedures. So the best advice I can give for that is that each store and each area have their own safeguarding protocol. So they might vary from place to place, from area to area. So it's really important that you follow through on what those procedures are. Majority of cases, you will have to follow it through with social services and they will give you more advice. For more information though on safeguarding, go onto the CPPE website. They do have e-learnings, e-modules and e-assessments on there regarding safeguarding. And once you are practicing as a pharmacist, you will have to complete those modules and complete that e-assessment anyway. So might as well learn it now. And that would be the safeguarding vulnerable adults and children section. Very interesting section. And yes, it's definitely something that you need to know about, particularly for when you are practicing. Another question I got asked was quite a specific one, and whether CD keys, so the control drug keys, should be kept on the pharmacist at all times. Yeah, keep them on you. Yes, we want to work in an environment where we trust one another and it's an open and honest environment, but if you leave the keys exposed in an area where anyone can easily grab them and get to, who knows what they'll do to that control drug cupboard, who knows what they'll take, what they'll pop out, what they'll spill. So to safeguard yourself in many ways, you keep the keys on you, because if there are any discrepancies and you're the responsible pharmacist on that day, it falls back on you. So keep the keys on you. So another question I got asked is a list of common microorganisms which can cause bacteria, viral and fungal infections. So if we start off with bacterial infections, for example, Staphylococcus aureus, viral infections, your herpes simplex, so you have two types, one which can cause cold sores, the other which can cause genital herpes, and your fungal infections which can be caused by Candida, so Candida albicans, which is, for example, for vaginal thrush, oral thrush, or another one which is called Trichophyton rubrum. Let's not pretend by now that I know how to pronounce words. We know I can't pronounce words, so just bear with me. Trichophyton rubrum. It's actually quite a fun one to say. In terms of specific antibiotics, though, that are effective against particular bacteria, something like your diaminopyrimidines, they are effective against gram-positive and gram-negative organisms. So, for example, it's effective against E. coli, Staphylococcus aureus, Haemophilus influenza. Something like your nitrofurantoin can tackle E. coli and staphylococci species. Gentamicin and tobramycin can tackle Pseudomonas aeruginosa, and something like streptomycin can tackle Mycobacterium tuberculosis. Yay, I got through saying the words. So with regards to drugs with driving warnings and drugs in sport, so drugs with driving warnings I've already covered, and I will put the link for that in one of these corners, whichever corner lets me put the link in. And with regards to drugs in sport, it's the UK anti-doping, which is the regulatory body that is responsible for the UK's anti-doping policies, and I will put the link to that in the description box below. So now moving on to the drug tariff. So the drug tariff is this big fat book, and it's written by NHS BSA and NHS Prescription Services Division, and it's issued monthly. You can get an online version as well, and the online version is probably a lot easier to go through than the actual big fat book. Don't stress yourself too much about drug tariff, but it is a really good resource, especially when it comes to endorsing. So that's what the drug tariff is there for, to help us endorse, know what payments we need to get, in terms of reimbursements, what we can get from it. And there's a lot of abbreviations within the drug tariff. So to go through some of them, BB means broken bulk, OOPE means out-of-pocket expenses, SP is specials, so if you do have a special product, when you're endorsing it, endorse it as SP. MF means measured and fitted, for example with a compression stocking. A black square, that's kind of a square. Black square means that you can't split it, and a black circle means that it requires reconstitution. And you also have ACBS, which is the Advisory Committee of Borderline Substances. Now this is found in Part XV, and it contains two lists. So List A is a list of products, and it states what conditions can be used or prescribed for those products. And List B is a group of conditions, and with that, what products can be prescribed for those conditions. So List A, products, conditions, List B, conditions, products. And in Part XVIIB, you have something called the Selective List Scheme, or SLS, and this is a list where only specific products can be prescribed to specific patients with certain conditions, only from those that are listed. So for example, you might see a lot of prescriptions for erectile dysfunction and sildenafil being prescribed, and it has SLS next to it, so that's what that means. And the drug tariff also has a list of those medications that are now blacklisted. So for your own knowledge, it is a good idea to briefly skim over the drug tariff, but I wouldn't focus too much on it in my own opinion. They might ask a couple questions on the drug tariff. Who knows what they're going to ask? But for your own knowledge as well, it is a good idea to go through, so just have a quick skim of that. Moving on to dressings. Now there are many different types of dressings, and what dressing you will use will depend on the situation. So for example, if a person has a lightly exudating wound without necrosis, then they may benefit from a low adherence dressing, for example your Gelinet dressings. If you have a dry, sloughy wound with necrotic tissue, but it's not infected, then a patient might benefit from hydrogel dressing, so something like intrasite gel or hydrosorb. You also have dressings that contain iodine, for example inodine dressings and idosorb, and these are really good for patients that have had burns, abrasions, or especially with the idosorb, it's really good for chronic exudating wounds. Now, because they contain inodine though, they are not suitable for children, those that are pregnant, breastfeeding, those on lithium, or those that have chronic hepatic impairment. In terms of absorbent dressings, it's in the name, they absorb a lot. So real exudating wounds, they will benefit from an absorbent dressing. So don't use it on a dry wound, for example, and you would want to use ones that are highly perforated, for example, your Mepor or your Melalin dressings. So you also have dressings that contain silver. So think back to the days when you had to learn the periodic table, and the chemical symbol for silver was Ag. So in terms of dressings, you have Alevin AG, Aquacel AG, so the AG refers to the silver that's contained within it. Nice and easy to remember. What are they good for? They're good for exudating wounds, infected wounds, but they are contraindicated in patients who are pregnant, have hepatic or renal impairment, or those that have G6PD deficiency. And you also have your vapor film permeable dressings, and with these ones they're good for exudating wounds but not for heavily exudating wounds. The benefit of them as well is that you can actually see through them and into the wound, and they can be used as a secondary dressing over an alginate or a hydrogel. Now examples are, for example, Tegaderm, Mepor film, Mepitil film and Mepor Ultra. So another question I got asked is which medicines should be stored in their original packs and how many days they expire once they are popped out of those original packs. So for example, there are loads, but I'll go through some of the key ones that you may have come across. So for example, Nicorandil. If you haven't seen a pack of Nicorandil, take it out and see the actual blister. Now, if you look at it, there's a little desiccant on the side, and that acts as a drying agent, so it prevents moisture from entering the tablets. So once one of those tablets has been popped out, that actual blister is only valid for then 30 days. After 30 days, get rid of it. So 30 days is the expiry date once it's been popped out. Something like dipyridamol's slow release, if you're opening from the original container, then it will expire in 6 weeks. If you've put it in, for example, a blister pack, a dosset box, or into another container, then it will expire in 4 weeks. GTN tablets, once you've opened it, 8 weeks it will expire. Madapar capsule tablets, if you transfer it into another container, then it will be only 2 weeks, which then it will expire, get rid of it. So there are loads. There's alpha calcidiol, which shouldn't be transferred into another container. Oromorph only has 90 days after you open it. After 90 days, it expires. Chlorpromazine syrup, that expires within 6 months after opening. With a lot of them, though, they will actually say on there how many on the actual packaging, what's opened, when you need to expire it. The GTN tablets and I think the dipyridamol slow release capsules as well. Those two in particular I have seen previous past paper questions on, but I mean they could ask it on anything, let's be honest. And I think when patients on a dosset box, it's really tempting to just pop out all their tablets. But for example, if they're on Nicorandil, it's benefit to risk, and you have to keep in mind that if you are popping it out, then it is exposed to moisture. It is a chance for it to get degraded a lot quickly. And I don't think it's very nice to give a patient degraded Nicorandil tablets. But yeah, so those are some of the key ones. So moving on to the behavioural change framework. Now, the behavioural change framework is one of my favourite things to learn about because I think it's so relevant in everyday life. And it's one of those aspects that you can use, for example, during an MUR. So what is the behavioural change framework? It's essentially what it says it is. It's about modifying a person's behaviour in order to benefit their health and well-being. And the typical example that is usually used is to stop smoking. So how can we go about doing this? Well, it's something called motivational interviewing. So it's about trying to get out of the patient reasons for them, for example, to stop smoking. And in order to use motivational interviewing effectively, we need to remember the rules of motivational interviewing. So letter R stands for resisting the writing reflex. Well, what does that mean? Well, if someone comes up to you and they say, I want to stop smoking, you might think, yes, you should stop smoking because these are the risks of smoking. These are the benefits to stop smoking. I'm a professional. You should listen to me. What you're doing is wrong. And obviously, as soon as you tell somebody that this is what you should be doing, naturally, they will start thinking in their head, well, actually, I like smoking because it keeps my weight under control. It helps when I'm anxious. It helps me when I'm stressed out. And naturally, they'll start thinking of ideas for them to carry on smoking. So it's very counterproductive telling someone, you should do this, you need to do what I'm saying. So the whole purpose of motivational interviewing is to get it out of the patient, their own reasons for why they want to stop smoking, and it needs to come from them. So you saying to them, oh yeah, you should stop smoking because it will make your breath smell better and it will save you money, etc., etc. Well, if a person doesn't really care about their oral hygiene, and if they don't really care about money, although who doesn't care about money? But if they don't care about money, then that's not really going to be something that is going to motivate them to stop smoking. It has to come from them and their own reasons. You also need to understand your patient, and that's where you comes in and rule. Understand your patient, understand their reasons. So it could be, for example, a female who wants to stop smoking because she wants to get pregnant. It could be that a person realises how much money they're spending on cigarettes and actually what they could be using that money for. And it's really key that you listen to your patients, and that's where L comes in. Empathise with them, try and understand and see where it is that they're coming from. And E is to empower your patients. So Make them feel like they can do this, give them that support that they need. And with something like smoking, let them know what is available out there for them, what other alternatives they can go through. Would they benefit from patches? Would they benefit from the lozenges, from the sprays, from inhalators? What would work best for them, and tailor it for that patient. And you have two more abbreviations, one called DARN and one called CATS. So DARN is looking at the desire, the ability, the reason and the need to make these changes. And CATS is looking at the commitment, the activation and the taking steps. So what steps need to be taken in order for this person to make that change. And if you use these frameworks, it really helps to structure your conversation when you are talking to patients about whatever change it is that they want to make in their life. So you have something called the trans-theoretical model of change, and this is something that I have seen come up in exam questions. They could give you a scenario and say to you, at which stage of the trans-theoretical model is this patient at? So let's go through the actual model and let's use stopping smoking as our example. So you have a patient who comes in and they say to you, you know what, I've had this really bad sore throat that's not going away. Could I get some simple linctus, please? And after you've asked them the necessary questions, you might then say to them, oh, by any chance, does anyone in your household smoke? And they might say, well, actually, yeah, I'm a smoker. Great opportunity to bring this up. You can then say to them, okay, well, have you ever considered stopping smoking at all? They might say, oh, no, it's not really in something that's been on my radar. And then you could say to them, well, that could be a reason why you keep getting these sore throats is because of the amount of cigarettes that you're smoking. Oh, you know what, that's a very good point. I didn't think of that before. They're pre-contemplating it. It's not something that was on their agenda before, but it's something that now they're, okay, I'm considering. Step 2 is contemplation, where they're actually like, you know what, yeah, you're right, I'm going to stop smoking. Step 3 is preparation. So what are they going to do in order to take those steps to stop smoking? Right, I'm going to stop buying these cigarettes, I'm going to buy those nicotine patches, and I'm going to use the little lozenges as well. Great. Step 4 is action. They're actually actively doing it. So they're using the lozenges, they're using the patches. And the last step is maintenance. So they're maintaining until eventually they might not need those patches or lozenges anymore. But at each stage, at every single step of the trans-theoretical model, there is the potential for the person to relapse and to fall back into going into old habits and going back onto those cigarettes. And that's important to keep in mind too. So it's a very useful model to use. Again, it's a good structure to use for your conversations when you have these types of conversations with your patients. And it is something that I could put in the exam too. So moving on nicely onto the healthy living pharmacies. Now, not every pharmacy is a healthy living pharmacy. You have to meet set criteria in order to be classified as one. And there's 3 main areas. One is your workforce development. So do you as a team proactively support and try and motivate your patients to benefit their health and their well-being? Do you comply with NHS community pharmacy contractual framework? Do you comply with the GPHC conduct, ethics and performance? Do you as a team, talk about health promotion and health and well-being? The second point is about, are your premises fit for purpose? So do you have a good enough consultation room? Do you provide MUR, NMS, flu vaccinations? And the third point is actual engagement with the local community. So do you get involved as a pharmacy with local and national campaigns, for example? So it is a self-assessment and you sign yourself off, but NHS England will check up on 10% of pharmacies that register as a healthy living pharmacy, just to check that they are being legitimate. I will include a link in the description box with the PSNC website, which will give more information with regards to healthy living pharmacies. But that's it in a nutshell, really. So moving on to MHRA warnings and class recalls. So if we'd focus on class recalls to begin with, there's 5 main types. Class 1 refers to that if you're exposed to this particular product, it could cause a serious adverse effect or even death. Class 2 means that if you're exposed to this product, it could cause reversible or temporary adverse effect. Class 3, if you're exposed to this product, it's unlikely to cause an adverse effect. With class 4, it will be withdrawn from the market, but it's not usually subject to violation and legal action doesn't usually have to be taken. And in the case of class 5, that refers to safety alerts, which will be put out. Now, more recently, sodium chloroglycate 2% eye drops, particular batches of those, they had a class 2 recall because precipitates were found in some of the bottles. So it is good to look at gov.uk for MHRA warnings and for class recalls as well. And if you sign up to it, they usually send you emails and alerts of the most latest recalls or the most latest updates that are available. And especially when you're practicing, it's really important that you do get fed that information. Now, in terms of the MHRA warnings, there are so many. And if I'm honest with you, so long as you've gone through the latest VNF, most of, if not all of those latest MHRA warnings are in there. So, for example, about live vaccines being used in immunocompromised patients, miconazole interacting with warfarin, updates on Levenel, EHC, in the use of patients who are taking enzyme-inducing drugs, which we've mentioned before. All these different updates, nicorandil causing ulceration, they are all in the BNF anyway, in the latest BNF anyway. Even in some of them are in the 2016 BNF as well. So long as you've gone through the BNF, you will actually be up to date with a lot of those MHRA warnings. So that's good to know. So taking a break from clinical, let's move on to some calculations. So you asked me to go over questions with regards to number needed to treat. Now, questions that ask about number needed to treat, get excited about, because so long as you use the formula, you'll get the question right, and they're really easy to understand. They're so easy to understand that even I understand it, which we know is saying something. So number needed to treat looks at your absolute risk reduction. So what does that mean? Well, it means that you're comparing an active group with a control group. So say, for example, your company creates a new anticoagulant medicine. You want to see how many patients are going to benefit from that anticoagulant medicine compared to, say, a placebo or your control group. So your number needed to treat will be 1 over ARR, your absolute risk reduction. And what this ARR can be broken into is 1 divided by PA over PC, minus PC even. As always, these posters I will put on Facebook and Twitter for you to have a closer look at. So what is PA and what's PC? Well, PA is looking at our active medicine. PC is looking at our control medicine. I don't know what the P stands for. I'm not going to lie to you. I'm guessing maybe probability, but even then, PA minus PC. So comparing our active with our control. So, this is a very simplified version of a question they will ask, but it's essentially the same kind of thing that they will ask. So don't get overwhelmed with complicated or big numbers, because it's essentially this. This is what you need to do in a number needed to treat question. And so long as you do this, it should be okay. So you'll get a table comparing what the active medicine and what the control medicine and the results that came about with that. So if we just try and understand this table, we can see that 60 people, they benefited from this new anticoagulant. Well, yes, 60 people did, but 35 didn't. So in total, we had 95 people that were taking this active medicine. With regards to the control drug, we had in total 98 people that were taking the control drug, of which 20 of them had success within it. So PA we said was our active, so it's our 60 divided by our total taking the active medicine, which is 95, 60 over 95. Our PC is looking at the success rate, so always looking at the success rate of those who took the control drug compared to in total who took the control drug. So looking at who were successful with taking the control drug over the total number of people taking the control drug. So that's 20 over 98. And we literally just plug the numbers in then. So we know that it's 1 divided by PA minus PC. We know our value for PA is going to be 60 over 95. We know our value for PC is going to be 20 over 98. And then we just 1 divided by that. And then depending on how many decimal points they want us to give the answer to, we'll give the answer to. That's it. It's that simple. So another type of question that you wanted me to go through was half-lives, and when the half-lives numbers that they use aren't the nicest of numbers. So this is an example of that. Say for example you have some medication which has a concentration of 980 milligrams per litre and it has a half-life of 6 hours. And the question is asking, what is the plasma concentration going to be after 27 hours? Now 27 isn't divisible by 6, so it means that it might be a little bit tricky. Because when it is divisible by, when the plasma concentration that they're looking for is divisible by the half-life, which most of the questions usually end up being, then it's happy days and it's easy to plug and pick up what the answer is. But when they do this to us, we have to do an extra step. And I think this is probably the easiest way of going about a question like this. So, start off with 980 milligrams per litre. We know it has a half-life of 6 hours, which means that in 6 hours' time, it's going to be half of that. It's going to be 490. In another 6 hours' time, so totaling 12 hours altogether, it'll be 245. In another 6 hours' time, again, it'll be half of that, it'll be 122.5. In another 6 hours, it'll be 61.25. And in another 6 hours, it'll be 30.65. So going from here all the way to here, 30 hours have passed. So we know that after 30 hours, it's going to be 30.625 milligrams per litre. That's not what the question's asking. It's asking for 27 hours. So 27 hours is going to lie somewhere between here, 24 hours and 30 hours. And 27, luckily, it's in the middle of 24 and 30. Therefore, all we need to do is find out what's in the middle of these two numbers. How do we do that? Add them together, divide by 2. It's like saying what's the number that's in the middle of 14 and 16. Add 14 and 16 together, divide it by 2, you'll get 15. Try it with any number. Do it with, let's go even more simple. What's in between 1 and 3? Add 1 and 3 together, divide it by 2, because we're using 2 numbers, and we get our answer. It's the same principle. Yes, dodgier numbers, but the exact same principle. So to find out what's in the middle there, add them together, divide it by 2, and we get our answer. And as I've said it before, make sure you know how many decimal points that the question is asking you for, and do that accordingly. So finally, moving on to drugs that are contraindicated in certain populations. And the two main populations I'm going to focus on are the elderly and children, so paediatrics. So the elderly. So as we get older, our bodies change naturally. And some of the things that you need to consider in elderly patients are, for example, the form of the actual medication. If it's a tablet, can they swallow that tablet more easily? Would they benefit from it being a liquid preparation instead? As we increase in age, we get a reduction in renal clearance, which means drugs are excreted more slowly, so causing a higher risk of nephrotoxicity. Hypnotics, diuretics, antihypertensives, they could all potentially cause an increased risk of falls in patients. NSAIDs cause an increased risk of getting bleeds, GI bleeds, and so as a prophylaxis measure, it's a good idea for the prescriber to co-prescribe a PPI, a proton pump inhibitor, if they are giving an NSAID as well, which is why on a lot of prescriptions, if a person is on naproxen or aspirin, ibuprofen, then usually something like omeprazole is given along with it as well. So you need to be careful with medicines that have a narrow therapeutic window. So for example, with digoxin. And drug-induced blood disorders, the risk of them increases with age. So for example, if an elderly person is taking cotrimoxazole, you need to be careful of that. As well as that, you need to take into consideration the pharmacodynamic and the pharmacokinetic differences that happen as we get older. So by pharmacodynamic, I mean looking at the additive and synergistic effects that medicines will have on the body, looking at whether a particular medicine is going to imbalance fluid or electrolyte levels. In terms of pharmacokinetics, so looking at how absorption, metabolism and excretion will be affected. And moving on to children, paediatrics. So on a prescription, if the child is 12 years old or less, then their age must be written on the prescription. If they are under 5 years old, then their age in years and months must be written. Now we can't think of children as little adults because their bodies are still developing, their organs haven't fully matured, for example, their kidneys and their liver, and their doses are usually based on their weight, their height, or even better, their body surface area. So if you're given a question and it gives you the option to use the child's weight or their body surface area, go with the body surface area. It's a much more reliable way of calculating the correct dose for the child. Now, with children in general, you might get a few compliance issues because they are very fussy. And little Susie won't go for the orange flavour, she'll only go for the strawberry flavour, but this particular medicine doesn't come in strawberry flavour, so Susie is just going to have to deal with the orange flavour. But obviously, children aren't always the best at being compliant with what you give them, so it can be a bit difficult. Also the formulation of the medicine, with a lot of kids, they won't want the tablets, they'll want the liquid, and even parents' opinion, that can take a big part, that can play a big part in compliance with medication in children as well. Now, putting medicine in a child's food and then giving it to them isn't usually recommended because the child may not finish all their food and then they won't be getting all that medicine into them. Now, depending on the age of the child, there's certain restrictions. So 16 and under, no aspirin. 12 and under, no codeine-containing products. Codeine-containing products aren't recommended for children that are between 12 and 18-year-olds either. If they're under 6-year-old, then avoid cough suppressants, particularly those that contain ingredients such as dextromethorphan or guaifenesin. If they're between 6 to 12 years old, again, you wouldn't really recommend it, and it would sort of be used as a last resort if the principles of best care had already been tried and failed, and you would limit the treatment to 5 days only. Now, with children, prescribers tend to prescribe a lot of unlicensed and off-label medication. Now, these two words I find that a lot of people get confused with and mixed up with. In both cases, it's using the medicine outside of its marketing authorization. So with an unlicensed medicine, you're using it outside its marketing authorization because it's not licensed for that particular medicine, for example, in this country, but it might be licensed for that particular condition in another country. Off-label refers to, again, it's being used, the medicine is being used outside its marketing authorization, but for a licensed condition. But you're just using it in a way that the marketing authorization doesn't say to use it. So, for example, it might say, take this pill, swallow with water. But instead, what you do is you crush it. By crushing it, you're now using it off-label. So that's the difference between the two. Now, if a person is pregnant, then particularly in their first trimester, so between the 3rd and the 11th week in particular, that's when it's the most dangerous to be taking certain medication, because that's when congenital malformations can occur. In the 2nd and the 3rd trimester, when particular medications are taken, it can affect the child's growth and development. Now, certain ingredients, they can affect children, so they should be avoided. For example, any that contain alcohol, such as benzoyl alcohol, any products that have the excipient as benzoyl alcohol should be avoided. If the child is lactose intolerant, then avoid products that contain lactose. If they have a nut allergy, then they should avoid arachis, particularly with peanuts. Avoid anything that has the excipient arachis. Ideally, you want to give sugar-free products to children because then it prevents them getting dental caries. But of course, with a lot of the time, little Susie likes the sugar because it tastes sweeter and it tastes nicer than the sugar-free. So it's really down to little Susie which one she wants. And I don't blame her, I like the sugar ones too. But yeah, if you can, give sugar-free if they will take sugar-free because yeah, it prevents dental caries. Benzodiazepines, they can cause serious withdrawal effects if they're taken during pregnancy or if they are given to a child. If a mother needs to take, for example, fluvastatin, she should avoid breastfeeding afterwards because then it is highly concentrated in the milk, it then can pass on to the child. Bromocriptine, that suppresses lactation, and phenobarbital can affect the suckling reflex in children as well. And if you think about something like nocturnal enuresis, so bedwetting, that's something that's really, really common in children. As the child gets older, they usually stop bedwetting, but if they're getting older and they are still bedwetting, then it might be worth telling the parents to look at the NHS website, for example, where there's a whole array of information on how they can help support their child to stop bedwetting. In certain cases, they might need to use an enuresis alarm, or as a last resort, they might need to go to their GP and get desmopressin. I'll include the link for the NHS website with regards to nocturnal enuresis, because there is plenty of information on there, and it's just good for your own knowledge in case a patient or parent ever asks you about their child. Good knowledge to have. And know your paracetamol, your ibuprofen, and I would even say your Puritan doses for children, because that's something that they will ask you in the exam, in the clinical paper, so you won't have a calculator, but they could ask it in the form of a calculation question in the clinical paper, and they'll want you to know it off the top of your head. So they might say, 4-year-old is taking ibuprofen, how much ibuprofen are they going to have in a day? And that's it. That's all they'll ask you. So then you need to know yourself, okay, ibuprofen dose for a 4-year-old, this is what it's going to be. They're going to take it 3 times a day. So, okay, this is the amount of total ibuprofen that they're going to have in a day. So make sure to learn those values. So when you're at work, pick up that box of Calpol, pick up that box of Nurofen, pick up that box of Puritan, have a read of them, learn them, know them. Because like I said, they will not give you those values. So I know this video was compact with a lot of information, but I hope it does give you a clearer idea of the areas that we've been through, and it helps support your knowledge and your understanding a bit better. And the very best of luck for your revision, guys. Keep in there, keep hanging on. It's all nearly over. You can do this. It's literally that last little push now. So just keep at it, keep doing what you're doing. Focus hard, revise hard, and just think it will all be over soon, and you'll be able to breathe and relax and be done with it all. But until then, very best of luck with your revision. I hope you found this video useful. If you did, why not give it a like, share, subscribe, comment, join my Facebook page if you haven't already, and like I said, I will upload all the calculations images onto there as well. Same goes with Twitter, so follow me on there too. And until next time, good luck with your revision and happy revising.